future events as well. So now I will hand this over to Keith Lamb, who will be moderating this session.
Good morning, folks, and thank you for joining us. Thanks, Madison, for the introduction. I wanted to start out with just a couple of things. We're asking all of the non-panelists to keep themselves muted so that we don't have a lot of background noise. We, as Madison said, are going to record this. We are recording this session, and we'll make it available to folks afterwards. We'd like for you to send your questions to the chat box, and we have a couple of predetermined questions already, but if we have other questions that aren't covered during the discussion, then please put them in the chat box and we'll try to address them. The folks that are the panelists today, I'm going to introduce them. I'm going to have them introduce themselves in a moment, but all of these folks are volunteers. Nobody is representing any company or institution. They've just volunteered their time because they're content experts, and so we appreciate them. So with that, I will go ahead and ask the panelists to introduce themselves. First, my name is Keith Lamb. I'm a respiratory therapist. I work at the University of Virginia on the Trauma and Neurosurgical Service. And Madison, can you introduce yourself?
Yes, so I currently work at UVA Health in Charlottesville, Virginia. I work primarily in adult critical care, and I've been RT for about 14 years.
Eric Kreiner?
I am also an RT. I work as the adult critical care clinical specialist at MedStar Washington Hospital Center in Washington, D.C. I've been at it for about 26 years.
Thank you. Tom?
My name is Tom Pereno. I might be the only Canadian respiratory therapist here on the panel. I'm an educator and consultant. I've been an RT for 20 years, worked in many avenues, bedside clinical research, clinical specialist, clinical educator, a lot of clinicals in there, and happy to be here.
Karsten?
Hey, my name is Karsten Roberts. I am an assistant professor at Thomas Jefferson University in Philadelphia. Been a respiratory therapist for 18 years, and I'm happy to be here.
And Joel Brown.
Hello, everybody. I'm Joel Brown. I am the CEO of Arrive Leadership, a respiratory therapist, and I am a consultant. I have 25 plus years of experience. Last 12 primarily in administration. So I guess my role is the grumpy administrator here. So I'll play it well.
Yes, you will, sir. So let me pull up our very first question. To the panel. I'm sorry. I wanted to also introduce Sarah Bazelic. Sarah?
Good morning. I'm Sarah Bazelic. I'm the Education and Quality Coordinator at Frederick Hospital in Milwaukee, Wisconsin. We are a level 1 academic center, a trauma center. We are about a 700-bed hospital, adult only, in Milwaukee. So we're excited to be here and ask these questions and have you guys all here to help us with this challenge.
And so also by way of introduction, Sarah is the person who requested this panel discussion and provided these questions. So the first question to the panel, how do you suggest a respiratory therapist or any other bedside clinician approach assessing ventilator mode settings to determine the correct mode being utilized? As an example, looking at the waveforms, the title presented on the screen, settings, etc. Eric, you want to start out?
Sure. So I think my first thing is that people will commonly rise to the level of their expectation, right? And so if we expect less of them, then I'm not sure that we can really expect them to supersede that, right? And so in the beginning, I think if you're going to play to a lowest common denominator, you're going to be stuck in that spot where you're going to be assessing whatever language or terminology that the ventilator is actually displaying to you, right? And so that is where a lot of people do get stuck, right? I'm in a multi-system or multi-hospital system. There's 11 hospitals, all of different varieties. I just happen to be at the 1,000-bed flagship hospital, right? And so all of the other community hospitals, I see the same thing struggle, right? That where this isn't a unique problem whatsoever at all. But if you're going to ask them, how do you determine a mode, right? Which is kind of maybe the first question going towards the end of what are we going to do about it? I do believe you have to take the information off of the machine, whatever it's giving to you. But then you are almost instantly translating it, right? So I mean, if you're seeing a proprietary nomenclature, it should automatically kind of compute in your head into something else, right? And so you can take that, but I do think that you need to go further to have people rise to the level of expectation, in that you can readily identify fixed versus dependent variables via waveform analysis, right? And then you can kind of start to pick your way through what mode that you're exactly on. So I think it is two-pronged. You do have to take what the ventilator is giving you, but I think if you're going to get to any sort of fundamental level, it is a waveform analysis, identifying what's fixed and what is dependent, and therefore what the control variable is, and go from there, right?
Tom?
I'm going to take it one step back and say the first thing you should do to assess whether or not your settings are correct or you're on the right mode is first to assess if you think the patient is actually breathing. So let's take it back and look at the patient, because if the patient is spontaneously breathing and you have them on a controlled mode where many of the variables are what's called set point, in other words, the clinician sets everything, then you need to understand which variables are set and which ones would be most likely to be affected by the patient breathing spontaneously. And it's not that patients can't be on a control mode while breathing spontaneous, because most of these modes are assist modes and will assist with every effort that they make. But that's the first step, because perhaps leaving them in a control mode if they've just begun to spontaneously breathe is not the correct decision to make. So in terms of determining what mode they're on, most ventilators will display the mode that they're on. And I know there can be some confusion with nomenclature, but to be perfectly honest, I don't think I've worked in an institution where more than 5 modes are used in total, and 3 modes are the most common modes used by everyone. So 90%, maybe 95% of the time, 3 modes are being utilized, and there might be an extra 2 modes that they use for either niche patients, etc. So those extra 2 modes might be PAV, NAVA, APRV. So understanding which mode they're on really comes down to, are they spontaneously breathing, and is it the most appropriate mode for them? So that would be my first step. And of course, looking at waveforms does help to determine that. Most ventilators will identify a spontaneous breath, whether it's a change in color in the pressure or flow waveforms. Sometimes there's a little icon of the lungs that are flashing at the top of the screen. This will indicate they're breathing spontaneously. And at that point, you would determine that if they're in a spontaneous mode and they're breathing spontaneously, the next question is, are their settings appropriate? And that's where you look at tidal volume. You can look at other measures for seeing if their work is excessive. So you can look at things like P0.1. There's a number of measures you can do to see whether or not the mode is supporting them appropriately. But first step is, are they breathing? And if they are, if they're not on a spontaneous mode, can we transition them to a spontaneous mode? And let's be frank, the most common spontaneous mode that everyone here is probably using 95% of the time is pressure support ventilation. regardless of what your ventilator calls it, that's the mode you're probably using when they breathe spontaneously for the majority of your patients. So ensuring that they get into that mode and that you adjust the settings accordingly. Yeah, so that's my 2 cents. Taking a step back and making sure you understand if the patient's breathing.
So isn't that Tom Eric, thank you. Isn't that sort of the crux of the problem, is what the ventilator manufacturer calls something? As an example that sort of drives me crazy is on the Draeger platform that we primarily use where I practice, you can switch the ventilator mode from volume control to volume targeted ventilation via the autoflow option, and it still says volume control. So you are getting a report that yes, the patient's on volume control ventilation, and yet they're not on volume control ventilation.
I mean, essentially, actually, if this is Abdul Fattah Musaid, if you could please mute your microphone. We can hear your children in the background. Thank you. I think, you're right at the same point. Whether it's volume control with with auto flow turned on or not, it's still a fixed flow rate. So you're still controlling the flow essentially, which is what a volume control mode is. So they're essentially by definition still on a control variable, a set point. You're just determining the direction of flow, whether it's constant or decelerating, but it's also a fixed level. Like it's not variable. It doesn't change. Having said that, again, if your patient is passive, does it really matter? If they're not passive and breathing, then these variables or these situations tend to start to matter a lot more.
Carson?
Yeah, I think that Eric and Thomas have already made some really good points, and I think going back to what Eric was saying about, I work in a 1,000-bed hospital. The chances are that you use multiple ventilator platforms in your institution. So it's really important to understand what language each of those ventilator platforms uses in order to understand and how they work. I mean, it's getting a little bit more complicated when you start getting into the inner workings of how a platform works. But if you can understand that a transport ventilator might call a mode of ventilation controlled, but the way that it functions on an engineering level, and again, I might be going too deep too quickly, but understanding that some platforms are turbine driven, if you're using that, and so you simply can't be in a volume controlled mode of ventilation if you're on a turbine driven ventilator that's used for transport. It's, you have to understand what you're putting the patient on when you make that change from the critical care ventilator to the transport ventilator is one example that I've seen in the past, that you start ventilating differently as soon as you do that. So you have to then if you don't understand that from an engineering perspective, you have to use what you already know, which is waveform analysis. And if you look at a waveform and you see that it's not what you expected it to be, so if I am in a volume controlled mode of ventilation, I expect to see the type of waveform that's in Thomas's background right now. But if I think I'm in a volume control mode of ventilation and I see a square pressure wave on the ventilator, then something is changed. Something's different than what I expected it to be, and I need to treat that patient differently. I need to assess that patient's work. I need to assess that patient differently. It really, I think that the simplest way of combating this issue is by looking at the waveforms first. I teach my students that your assessment starts from the beginning, from the moment that you walk in the room. So as soon as you enter the patient's room and you start seeing what you see, like Thomas said, are they breathing? If they're not breathing on their own, then they're being controlled by the ventilator. If they're breathing on their own, maybe they're on a pressure support mode of ventilation, maybe they're not. But your assessment starts at the beginning by looking at the patient and see what they're doing, and then start to look at your waveforms and see what the ventilator is telling you about what the patient is doing.
So Carson, I was going to ask you, you're primarily at this point an educator. And so what do you do as an educator to sort of address this? So addressing this in the ICU with respiratory therapists that are already graduated RTs may have different nuances than trying to educate folks in the classroom. What kind of tools do you use to sort of get this across to your students?
I think it's a really a back to basics kind of methodology that I'm implementing here. By teaching our students initially what an AMBU bag is and how an AMBU bag functions, I think that I can then build off of the concepts of you're setting a tidal volume by squeezing the bag. You're setting an I to E ratio. You're setting a tidal volume. You may not know what all of those numbers look like. You can't assess that in real time, but you really are doing the work of a ventilator. You're oxygenating the patient. You set an oxygen flow rate. You set a tidal volume and a respiratory rate. And if they can start to begin to understand those concepts and then move toward what non-invasive ventilation looks like, and then start to introduce the concepts of volume control and pressure control, once they have understood those initial simple concepts, I think that it's easier to then kind of sprinkle in these ideas that, well, maybe the ventilator says that you're in volume control, but is it really?
Good. And we left the grumpy administrator for last. Joel, as an administrator, what's your advice on how to trickle down solutions to these issues?
Yeah, I mean, I guess I'll start off by just saying everything they said is accurate. And as an administrator, my expectations that our RTs are going to be able to do this work. This is what makes us unique. It all starts off with the patient first, right? So nothing's more drives me nuts more than going in a room and everybody staring at the graphics, and wondering why there's a leak. But you can see that the inline suction's filled with air because the gasket's broken or something of that nature. So starting at the patient, I think our RTs need to be very familiar with graphics. On top of that, and knowing how to determine them, and then the part that especially rolls around this, which is around taxonomy, is knowing the ventilators you have and what modes equal what on when you're switching around. A great example of that is if you had a patient that was on a Servo 300 and they were at the PRVC, and they're going transport, that's in a Hamilton T1, that's a synchronized controlled mandatory ventilation plus. Most people don't know that, right? But it's the exact same thing. And I think our RTs, to trickle down to that, is make sure that everyone knows it, because it takes that one time that we're called in and we're not aware, becomes the example of why people start looking at what is the value of having our RTs there. Rarely happens when you have it, when folks know this. One of the things that I always recommend, especially as we bring in new ventilators, is that my team absolutely knows what mode equals what on the other ventilator, because we know that there are 300 plus names for different modes, but we really, like someone said, we use 2 or 3, right? 3 is the max, and then when we get real fancy with a couple of the outliers, we may use an extra mode or 2 for some really sick patients. So I think to make it simple, is for us, but still slightly complex for the folks that we serve, meaning the physicians and all those guys. So they recognize the level of understanding that's required to get to that level of simplicity is important, if that makes sense. So number one, start at the bedside, know your graphics well, understand your equipment, and then know what the equivalents are when you go from one device to the other. If you could do that, you'll be a successful department, and it'll make that I have less conversations that are uncomfortable. And the ones that I really love is when someone thinks, I mean, I get the call from a physician or get the call from someone who's probably not as aware as the bedside RT, who thinks that a mistake was made, but it just points out that they don't understand the level of complexity for our equipment and how we utilize it with our patients. So long story short, patients first, know your graphics, understand your equipment, and then make it simple at the end of the day.
Yeah, so Joel, just to follow up on what you just said, and I think that the next question we're going to pose here will get more granular about this issue. But is it more important, and I'll put this out to all the panelists, is it more important to understand the translational issues between one ventilator and another? In other words, the nomenclature, is it more important to understand that? Or is it more important to be able to look at the screen, look at the settings, look at the interaction, and then know that that's the same thing as the ventilator setting that the patient was on before?
I'll start it off since I ended it.
Oh, go ahead.
I would say both. They're both extremely important. And I'll tell you an administrative part, and then you guys can go and jump into the more detailed clinical. I can tell you for an administrator, it's important because I've been in situations where Joint Commission has come and they start questioning ventilator orders, and say like I said, a patient's being transported from one ventilator to the other, and meaning they can't be transported on an ICU vent, and you have a different transport ventilator, and they see that because part of some folks, their documentation is the actual mode that's on the ventilator versus using taxonomy, right? And so they asked immediately, why isn't there an order for this mode change? If your team's not able to easily explain that, then it's like they call it pulling a string. Then they go down this rabbit hole, and then you put a lot of energy in finding out that they actually knew what they were doing, and they actually had the person on a comparable mode, but they just couldn't explain it at the bedside. So to me, having some clear taxonomy or knowing exactly what it means, or having some kind of aid. Actually, I believe there's even an app that some of the places I do consulting for use that app that tells you exactly what the modes are for it. But having something like that's super important, just as important as knowing the bedside part will save the patient's life. But after that, if you have things and folks don't understand it, there's a lot of opportunity for danger.
I think Joel's comment kind of leads into one of the questions that came into the chat there, Keith, just about how do you deal with the lowest common denominator? Because obviously someone coming in and asking these questions, they're a lowest common denominator, as are residents. So as someone who's been teaching residents for 13 years, I can tell you that they are a lowest common denominator, probably more so than many of the bedside nurses that we work with that we assume don't know as much as ventilation, but residents really don't know much about ventilation when they're coming in. And one of the things that I've done historically, because when it comes down to the mode names, I agree with what Joel's saying that, you may have volume control ventilation written in an order, but then the mode on the ventilator is called something different. This really comes down to a problem with the ventilator manufacturers, and they really need to sort that out because as clinicians, we can't control what they're naming their modes. So we just have to know how we can educate and teach. And as Joel mentioned, having some sort of reference or guide. And that's my answer to the question in the chat is historically what I've done is I've picked the most common modes used in the ICU in which they're working in. If there's many different ICUs, you include those modes, but typically you end up with about 2 or 3 modes, and you just describe what the overarching mode, or you could use the overarching taxonomy for volume control, for example, and then you list out the ventilator and what that mode is called on that ventilator, because you know that when they choose that ventilator, and if they're using volume control or pressure control, this is the name of the mode on that ventilator. And most RTs, when they get a new ventilator, they're going to say, how do I set pressure control, or how do I set volume control? They're going to ask, how do I set the mode in which I'm most comfortable and most commonly using, and each ventilator will have it. So having that list, and then you review some of the variables, like how is the ventilator breath initiated, patient versus ventilator or both? How is it initiated? What is the target? So is it a volume and flow target, or is it a pressure target? How does the ventilator know when to stop giving the breath? So the cycle criteria. And then of course, PEEP and FiO2 is sort of this universal setting for most of the ventilators. So creating a handout that's available for residents and for bedside staff that are coming on new, this is probably the best way to have a consistent answer, because that was the question. How do you give someone the same answer all the time? You have to have a prepared document that everyone is comfortable with in sharing, rather than relying on one person to be like, oh, well, this is this and this is this. If someone asks you a question, you say, you know what, let me get you the document that we prepared that helps to summarize all of these documents, because then you cover your butt. As Joel was mentioning, if someone comes in and say, how do you know what you're doing is safe and appropriate, you can say, well, we've all referenced this document. You can even have people sign off that they've read the document. There's a number of things you can do to ensure the safety of that. But yeah, I really do think this whole taxonomy thing it's more of a problem for the ventilator companies. I don't get too deep into teaching it, and maybe this is another discussion, because the next question I know, Keith, you're going to get into is how do we teach these taxonomies at the bedside? And to be perfectly honest, I don't get too deep into it because, lowest common denominator. So sorry, Karsten, I think you were going to make a comment before I jumped in on that question.
Now I have another thought though. So I think
that's why I did it for you.
I think you're absolutely right though. I mean, you can't teach the taxonomy at the bedside because we haven't taught it in school. And even though our textbooks now include the taxonomy, there's most of us don't know it well, and so so I think that if I as an educator can start with the taxonomy in school and really teach it well, but then I'm faced with another problem, right? Because now I'm sending graduates into the workforce that speak a different language than the workforce itself. They're like, well, why don't you know what I'm talking about when I'm saying set point? So it's really important, as you said, to teach the basic modes: volume control, pressure support, ventilation. Those are the three most common things. Let's teach that, and then like I said, sprinkle in the other parts of it. And Joel actually said something that made me think, well, we talked about like what we're looking at the screen. You come into the ventilator and I see that it says SIMV plus. Well, I know what SIMV is. I know that I'm in volume control or pressure control, and I know I'm in SIMV, but that plus should trigger in my mind as a clinician coming to my patient that something else is happening in the background. Even if I don't fully understand what it is, I need to kind of start thinking about what else might be happening. If there's an additional of like, oh, there's autoflow, or there's this plus, or there's this other thing that is not that original mode that I thought that I was in. There's also this kind of additional thing going on in the background, and we have to start digging into what that means.
Eric, did you have any follow-up on what's been said so far?
I mean, I think I would just reinforce the pragmatism, I mean, the taxonomy is fine. It is what it is. And it's and it has its place, right? But there's also a pragmatic approach to it where you at some point have to be have functional understanding of what it is without, without a tag and everything else, right? And all of that is there, but the pragmatism is, I think, what you have to go at, right? And but I mean, maybe just looking at some of the time and kind of where the conversation's leading, I mean, the way that we have I guess addressed the whole thing is it's a complete commitment to something, right? From the educational foundations that are set up for every single discipline, right? From the nurses to the residents to the fellows, and quite honestly, the attendings, right? And so then to the therapists. Then it is a reinforcement within the orders, a reinforcement within the documentation, and then a reinforcement within the interdisciplinary communication. If you're going to land on, we're going to call this VCAC, and we're going to call this PCAC, and we're going to use a pragmatic approach to the nomenclature, the taxonomy of the mode, and so that we all understand what this is, you got to make a full commitment to it, right? You can't have the only thing that may differ is all the way at the end user point where they are translating it right off of the machine. But then from that point on, everything is VCAC, PCAC, or pressure support, right? Because if you're starting to, if you do one without the other, right, then you kind of create an inconsistency, which is what the problem is, right? There's an inconsistency in communication and naming and understanding and everything else. And so I think the consistency in the approach has to be there all the way through. If you have, fields in your EMR that are actually calling it something else, right? Other than what you've landed on as this is the generic pragmatic nomenclature that we're going to use, you're setting yourself up for failure at that point, right? Because you're, again, speaking a different language kind of going through, right? There should be one translation off of the machine, and then everything else is spoken within the same language, right? And it takes a commitment. It takes a huge commitment. And it takes a persistent commitment, within the pulmonary critical care and critical care fellowships, in which I'm, faculty. We've published a bunch of different articles based off of the same mechanical ventilation course. Has produced a ton of research that we've been doing. And we've been able to show a degradation of knowledge despite clinical application, right? A degradation of foundational knowledge. Even though we let them go out and practice and then bring them back, 6 months later and kind of reevaluate them, they do really poorly on the comeback, right? And so where we've landed in kind of this evolution of how we've have addressed this over a 12-year period, 12 to 15-year period now, is the fellows, the therapists, while they're in training, they go through the same mechanical ventilation course, and they go through this course, which includes a preceptorial. So what we understand is we can hit them with a whole bunch of material at an onboarding, and then we let them go. And we bring them back 6 months later, and we can kind of reevaluate and retest on the same material. And we know that they forget everything. They're back down to where they were at the start, despite day after day after day of clinical application, right? And so what we've done is kind of assigned a chapter, and they're simple. It's pressure versus volume. And they have to make an appointment with me every month. A 90-minute slot, and then they have to come. They're assigned a chapter, essentially, 10 of them, and included in this chapter is clinical cases, kind of a workbook based on the conceptual theories, right? What are all the phase variables, and digging deeper, into each one of them. Drawing the waveforms for each one of them, right? And all of the literature that's underneath. And they get this packet, and they get X amount of time, 3 weeks to go through it. And by the end of that month, they have to make this appointment with their preceptor. They come back, and they have to teach it back to us, right? And then that's month 1. Then the next month is chapter 2, and it's a different topic, right? And what we've been able to do, and it's hard, man. It is so hard. It is so busy. you know, depending on the cohort that you're training and who you are. So you have to build the faculty in the same way. But we've been able to do it with a lot of success in being able to sustain it. That these monthly visits that keep coming back and keep re-explaining this, because what we believe is that there's a difference between knowledge and fluency, right? There's an absolute difference. You know, man, I took 6 years of Spanish. I took 4 years of Italian. I couldn't order breakfast in any of them. I couldn't. I got A's in every single class, man. Every single class. So I have a knowledge, right? And I can kind of, oh, that's Spanish. I kind of know what that means, right? Or I hear this, or I can see it. That's knowledge. There's a vast difference between knowledge and fluency. And until you reach that fluency and somehow set up a system in which to work towards it, I think you're always, you're never striving for the top level of it, right? You're going to stay down at the lowest common denominator. So we've addressed them. We've addressed the lowest common denominators in the same way, and you know what? I think it's a commitment on behalf of the leadership and your medical staff and everything to say, you know what, if what you got into this isn't what you're still in it for, then maybe this isn't the right place for you, right? And like if you really just kind of want to go hit a clock and do some documentation, then there's like 40 other hospitals in this area. That's the deal. But here, you're going to prove your value and your worth at every single opportunity. And you're going to answer the question, what do you do that nobody else can do, right? And until you're fluent in any of that, then you're not going to be at that level, right? And so it is a systematic approach that takes a multi-pronged attack to it, right? And it's hard. It takes a lot of time to get it off of the ground, but the agenda and the course and all of that, that isn't what we're talking about. It's the consistency that I think is there, right? I think there's a lot of research on education that you got to repeat something 7 times before somebody can actually hear it or something like that, right? And there's a clear demonstration of a degradation of knowledge over time until you immerse yourself in it and do it, right? And so that's how we address it. That's how we address the lowest common denominator. That's how we address the entirety of the issue of mechanical ventilation and what we call it versus what it's telling us. It's a consistency in its approach, and it's a complete commitment to the educational foundation of it at every single level, right? Like even my nurses, I go in there, and it's a joy to hear because I don't see them in their ICU nursing fellowship until 6 weeks in. And we kind of start talking about nothing knobology, all conceptual. But when we get to the modes, they say VCAC. And I'm like, this is beautiful, right? Like you're not calling it something that you learned in school or anything. This is what it is, VCAC. We're not dragging something out, right? And so, and then I'll shut up. But the other thing is you have to be able to point out in a realistic way the downside of not doing it, right? Because I think a lot of people can appreciate the upside. A lot of people do, right? And because if you give them this, that they're going to gravitate towards it and they're going to eat it up. But you're always, and so now I'm addressing the lowest common denominator. You're always going to have, I don't want to do this. Well, okay, we have that conversation, and we happen to share a campus with Children's National, right? So we're an all-adult hospital, except for a 45-bed level 3 NICU because we do all the high-risk deliveries for Children's National, and they stay with us unless they need surgery or ECMO. So it's the weirdest setup ever that we're super sick tertiary referral center for all adults. And we got this little NICU that's like up in Babyland, like it's just over there, right? And so there's a complete disconnect, right? But if you can make the point that, man, if I just call this assist control in my adult ICU, I can walk up the stairs, 3 flights down the hall and land in my NICU in front of an isolette and say the same word, assist control, and will mean an entirely different thing, right? Volume is our conventional in the adults, pressure is our conventional in the babies, and that's what we used to do, right? And you gotta keep at it. You gotta keep at it, but you gotta have the systematic approach to it.
I'm gonna tackle. Oh, sorry. Go ahead, Keith.
Just real quick.
I was going to tackle one of the comments or questions in there, but go ahead.
A couple things real quick. First of all, this is why I ask you guys to be on this panel, right? I'd like to get my 90-minute appointment with you, Eric, at some point in time. Something that something that you said about, and man, I say it at least to myself several times a week, maybe not out loud, but something I say to myself is, man, maybe you're just not cut out for this. Maybe this isn't for you. And when you referred to that, and when you said that, I can see everybody's face, whose faces I can see now, just kind of like light up and say, yes, that is a phenomenon that's out there. And unfortunately, we don't have a really good way of tackling that, I don't think. Go ahead, Tom. I'm sorry. I was
just going to say one of the things that is, it's not a term I'm making it up, but it's a term that I don't think we use, or a technique we don't use enough with teaching mechanical ventilation, is teach back. So Eric was mentioning like people coming and having 90 minutes, and having people teach back to you what you're teaching them is extremely important, because you can teach a staff therapist the nuances of a mode several times and they can pass a test, for example. But then if they're not teaching it and explaining these things themselves, just like Eric said, he can't order breakfast in Spanish. It's because you're not using it. You're not doing it, right? So you learned it, you passed your test, you got A's. But then if you're not actually using it, meaning you're using a ventilator, but how many people, when they go up to a ventilator making adjustments based on a blood gas, are sitting there going, okay, so the control variable is flow and the volume, and then the time is, it becomes pragmatic at that point where you understand yourself how the mode functions. But then when you get asked to explain that mode, you seem to be a non-expert. Like you fall apart if you're not teaching this and you're not understanding these nuances. And again, keeping it to the lowest common denominator, being able to explain a mode in its simplicity for the lowest common denominator in a way that allows the receiver of that education to understand what's the most important thing to be able to recognize with this mode when something is wrong with the patient. So forget them, a bedside nurse doesn't need to realize whether or not flow of 2 liters per minute for trigger is better or worse than 2 centimeters of water of trigger. Like that's up for us to understand. Like that's not going to change the bedside nurse's perception, but understanding which variable is going to change when the patient decompensates. So if they're in pressure control, volume is extremely important because you're not guaranteeing the volume. If they're on volume assist control, peak pressure is most important. This graphic I have behind me, in volume control, you can set an inspiratory pause of 0.3 seconds. Then you get plateau pressure measured right there. These are very simple things you can teach at the bedside to say, listen, if my peak pressure goes up, let me just get my hand. If my peak pressure goes up, but my plateau stays the same, my patient may need suctioning. There's something wrong with resistance. Whereas if you say, if both of these go up, if peak and plateau go up, maybe call me because I may need to do some interventions. I may need to lower PEEP. I may need to increase PEEP. There's other things we may need to do, but giving them the strength to be able to recognize these things, but keeping it simple. They don't need to know, the equation of motion. Again, the lowest common denominator doesn't, but I think every bedside clinician needs to understand the equation of motion. And that's something that they should be able to teach back and understand how the modes play into that. When you introduce PMUS, like a patient making an effort, how does that play into the mode in terms of this equation? And then you start to understand how modes function a lot easier. But yeah, really having staff teach back is probably the most important thing, particularly when you are in an education facility. So if you never get residents and you never get doctors and you rarely get nursing turnaround, you can probably cruise by. Everyone will just think you're an expert and no one will challenge you on this. But if you work in an institution that requires a lot of education and bedside questions and stuff, then having these resources available, like the cheat sheet on mode nomenclature, would be helpful, but also being able to teach back. So you don't have to say, oh, let me call the educator, they can educate you on this mode. Every staff should be able to do this. But if you're not practicing this, it's not happening. And unfortunately, I'm going to come out and say it, most RTs that are teaching students at the bedside, they glaze over the nuances of mechanical ventilation simply because they haven't been teaching back. They are not teachers of these modes of mechanical ventilation. So the knowledge that the staff therapist is imparting onto the new student is really, what do you do when this doesn't work? Well, we have this little thing that we fix that, like, we teach them how to fix things at the bedside, how to troubleshoot things, but we don't often have very good preceptors that can teach at the level of an educator. But that's unfortunate because we all should be able to. Anyways, I'll stop talking there. I made enough points. People can comment on that.
But I mean, I think it's a really good point, though, Thomas. Teaching is one of the most important skills that respiratory therapists have to have in order to be successful. In one of my previous institutions working night shift, the respiratory therapist would ask me, why are you always sitting at the desk with the residents at night? Why aren't you in here hanging out with us? I'm like, because they're learning, because I'm getting to know them personally and professionally, and I'm teaching them. They're curious. They want to know. And so, but then in my educator roles that I've had in hospitals, everybody's like, well, let me call the educator. Let me call the educator. Well, look, you can't rely on the Andy Kleins of the world to teach every time. You should be able to teach the same concepts that Andy can in the same manner that any of the educators on this call are able to do. And it doesn't matter if it's to nurses or residents or APPs, and it doesn't matter where you work. You should be able to teach these concepts and speak to them well.
I love that. And I'll end with this. So, I always say that, as a leader, there's a couple things you need to do. You have to figure out what are the things you need to do, what are the things you need to teach, and what are the things you should ask other people to do, right? And the teaching part becomes super important. There's a certain level of RT that can explain things to each other, right? And because we roll right into technical terms and start talking about TIs and start talking about, the inspiratory time and PEEP and all these terms. But man, can you get in front of a resident or even a new nursing student or a nurse that's in a fellowship in the ICU and explain a complex mode to her? And if you can do that to me is when you're at that next level. They're the folks that I'm looking for to become educators themselves, because taking a really complex concept and then making it that everyone else can understand it, but at the same time know that this is too complex for you, is super important, right? Because you don't want to dumb it down. You want to make sure you're being accurate, but you want to make sure that people walk away understanding. So I said always because I was an educator for 7 years, a staff development specialist for the respiratory department. And I always say, first start being able to teach it to your colleagues, and then go home and teach it to someone like your wife or your spouse or your loved one, someone that has no idea what it is. And if you can get them to understand it, then you've reached that apex. So I would say that, and it's a big part of leadership is being able to teach complex concepts so people understand it, but also are intrigued enough to learn more. And go to Carson at the side and go, Joel or Keith just said this. Tell me more about it, right? Then know that it's so complex that I should reach out and get more information. So I commend you for that.
Yeah, I would say that. Well, first of all, I feel like we covered the second question already. So I'll just continue with what we're talking about now. Carson said something earlier about how he is going to be sending new graduates out to a workforce that doesn't speak the same language. And I haven't seen this yet, but I'm looking forward to it. I think that when that occurs, there'll be more benefit to that than than not benefit, because a student challenging the current status or the current knowledge base of the staff RTs will be enlightening to the staff, I think, and will certainly make them more motivated to learn themselves. So anyway, I agree with everything that's been said. I do appreciate the fact that there's a whiteboard in every patient care room in our ICUs, because I use them. I come home with markers on my hands because I like to draw and I like to teach in that manner. But Joel, I don't know if you remember way back in the day when we used to work together. I used to be given a 4-hour block of time to every couple of months to specifically get in front of the surgery residents and teach all the things that we're talking about right now. And I think that I couldn't agree more that the RT is really whether or not you're a professor at a big university or you're a bedside leader, that your primary role, besides making sure that people are taking good care of patients, is to teach. And so whether or not that's teaching the bedside nurse, I've had many times where I've discussed something with an RT in the ICU, and then the nurse would come up to me soon thereafter and say, "Hey, do you mind going over that again with me, because I'm interested in hearing a little bit more about that." So yeah, we're definitely educators, whether or not we working at the university or not. Most of the comments in the chat box are just that. They are comments. Some of them are questions. I'm going to try to, we only have a few more minutes of protected time here. So I wanted to just go over some of these that are questions. Madison asked, what advice would you give to RTs that consider themselves leaders that are not in charge? How can you tactfully teach this at the bedside?
I wrote something in the comment section to respond to that. And so I'll say it again. You are a leader. Our role requires you to be a leader, just flat out. We're the cardiopulmonary experts at the bedside. So the title has never identified leadership as far as I'm concerned. That's why I love working with flat facilities where, like, basically there's one person with the title and everybody else is like within the same space, because everyone has an opportunity to lead. But it all comes down to speaking up for others, and you should be, as the expert, you should be speaking up for your patients. And the best way to demonstrate leadership is by doing it by example and speaking up for others, and that's a great example. The first place and the best place to identify yourself as a leader is during rounds. Go to rounds, be active in rounds, not on the outside, not waiting for them to finish and come back and tell you what was said. Prioritize it. And Keith can tell you, when we work together, we prioritize rounds. In fact, we got our physicians to the point that if you weren't at rounds, you got a call and they waited for you. And let me tell you, when you got there, you got some really sour faces because
they wouldn't start rounds. They wouldn't start rounds unless we were there.
We made sure that was our standard. You did not start rounds unless we were there. And to me, that's the place to show that you're a leader, right? Your title says respiratory therapist. That means automatically you have that. And so showing that you identify the information, that you know where this patient should go, you're speaking up for the patient, you're willing to teach folks that don't understand it, and that you're going to follow up, right? So don't wait for the title. Charge and all that stuff's great, and I recommend that everybody does it. I already say the reason why everything I needed to know as a leader that got me to my administrative role, I learned as a charge therapist. And I mentioned that at the ARC. But I will tell you that you are all leaders. You have to act as such at the bedside. The best way to start, be there for rounds. You'll learn something, you'll teach something, and people will see you as the leader you are. I could do a half-hour talk on that, so I'm going to jump off.
Yeah, I teach and preach that every day. That rounds is invariably the most important part of the day. The most important thing that you'll do. You'll teach, you'll learn. I mean, just as much as teaching, I learn in rounds. And I'll hear about something I've not heard about before. Even an old guy like me that's been around doing this for a long time learns something new every time that we round on patients.
Absolutely.
Anybody else have any more follow-up on anything?
There was a comment or question in the chat about why there isn't different levels of education for this. And
public.
yeah, I think it's important that we understand ourselves as the experts. And we all know that there are now different levels of respiratory therapists because we've had the introduction of the APRT. But here's my feeling on that. The APRTs are going to get busy. They're going to get to the point where as extenders of the physicians, they're still going to need us to back them up. So we still have to be experts. So even if the APRTs are taught at a different level than a registered respiratory therapist working at the bedside, we're still going to have to be there to back them up and to support them, regardless of that, because they're going to be doing other things. That skill set is different. They are working as a critical care physician extender in the ICU. So we still have to be the experts. And so there may be a time where that education continues and there are other respiratory therapists that are experts at a different level than us. But as the registered respiratory therapists, we need to maintain our education and continue to understand these things.
Anyone else have any closing comments from the panelists? Okay. So in closing here, I just want to thank everybody. I'm going to try to put this information on the screen real quick here, if I can figure out how to do this. So here's contact information. Contact information for myself. I can reach out if you send me a message. I can reach out to any of the panelists. Some of the panelists have put their contact information up there already. I want you to. So this was our first panel discussion. I hope that everybody enjoyed it and I hope everybody got something out of it. I want to remind you to please leave recommendations in the chat box. If you have recommendations for future panel discussions we can have, then we'll set them up. The best way to do that is to go to our website that is on the bottom there, www.inspired-rt.com, and go ahead and sign up for that, because then you'll get a survey that you can fill out to give us more information. And if you don't mind just letting us know how many people were in your group, if you had more than one, we're trying to get a feel for what kind of participation we had for today. So all that being said, we appreciate all of you for showing up. We'll keep in contact with you all the best we can and let you know what future discussions that we'll have. So you guys have a great day. And again, thank you to the panelists and to the participants. Joel, did you have your hand up?
No, that was just a hand clap.
Oh,
Just
you're
using the
clapping.
tools.
Nice,
Yeah.
nice. All right, folks. Well, thank you so much. And you guys have a great day and weekend.
Thank you, Keith.
Thank you.
Goodbye, everyone.